Thank you for this opportunity to speak today. This session will focus on the role of lipoprotein a, or Lp(a), in stroke risk, talk about practical testing strategies and collaborative approaches with cardiology and prevention teams. This talk does not reflect the opinions or official recommendations of the AHA. My name is Kavya Parachuri, and I'm a lipidologist and preventive cardiologist at Massachusetts General Hospital in Boston, where I also serve as Clinical Operations Director for the Cardiovascular Medicine section and as the Medical Director of our Lipid Apheresis Unit. These are my disclosures, mostly related to grant funding paid to my institution for clinical trial work. I also participated as the MGB Health System Champion in the AHA's LPA Discovery Project. My objectives today are threefold. First, to clarify the role of Lp(a) as an independent risk factor for ischemic stroke and highlight the clinical scenarios where testing is most informative. Second, to walk through practical approaches to LPA testing and interpretation in stroke patients, including how to interpret and discuss these results with your patients. And finally, to outline collaborative risk management strategies, working with cardiology and preventive teams to help optimize vascular outcomes in patients who have elevated Lp(a). LP is often thought of as a cardiovascular biomarker, but it has direct relevance to stroke biology. On the right here is data from the Copenhagen General Population Study. The x-axis here shows age, and the y-axis shows cumulative incidence of ischemic stroke as captured by the Danish National Registry, adjudicated by physicians. The three curves here are stratified by LPA concentration, from low in black to intermediate in red to high in blue. What's striking here is that these curves track pretty closely together early in life, but begin to diverge with aging, reflecting the cumulative exposure to elevated LPA. By older age, individuals with the highest LPA group have a visibly higher incidence of ischemic stroke compared to those in the lowest group. And there's a statistically significant trend across the categories. Quantitatively, compared with individuals in LPA below 10 milligrams per deciliter, which represents lower than 50th percentile, those with levels above 93 milligrams per deciliter, representing above the 96th percentile level, had a 60% higher adjusted risk of ischemic stroke. Across other observational and cohort studies, LPA has been independently associated with stroke risk, with estimates ranging from a roughly 20% increase up to a twofold increase, independent of traditional vascular risk factors. Structurally, LPA looks a lot like LDL, but it behaves very differently. Like LDL, it consists of an ApoB-containing lipid core, but what makes it unique is this additional apolipoprotein a, or ApoA. ApoA is composed of multiple Kringle-4 type 2 repeats and is structurally homologous to plasminogen, as highlighted by that teal curve on the right. This means that LPA can compete with plasminogen and impair fibrinolysis, creating a prothrombotic signal that is directly relevant to ischemic stroke. In addition, LPA carries a high burden of oxidized phospholipids, which promote vascular inflammation and calcification. So LPA combines three mechanisms that we care about in stroke: atherogenesis, inflammation, and impaired clot breakdown. That dual atherosclerotic and thrombotic biology helps explain its association with large artery disease, recurrent events, and cryptogenic stroke. LPA levels are largely genetically determined, with about 60 to 70% of plasma concentration explained by variation in the LPA gene in particular. This is driven by the number of Kringle-4 type 2 repeats across the two LPA alleles. A higher number of Kringle-4 type 2 repeats produces a larger ApoA isoform. These larger ApoA isoforms are retained and degraded more within the hepatocyte and endoplasmic reticulum, thus resulting in lower circulating LPA levels. In contrast, the smaller ApoA isoforms are secreted more efficiently and are associated with a higher plasma LPA concentration. So paradoxically, fewer Kringle repeats translate into higher lifelong exposure to LPA. Because the Kringle-4 repeat number is genetically encoded, the plasma LPA levels are largely genetically determined. The primary driver is variation in the LPA gene, as I mentioned, but there can also be influence from the ApoE and ApoH genes. As a result, LPA levels are stable after childhood and remain relatively constant across the lifespan. Globally, elevated LPA is present in roughly 20 to 30% of the population. But importantly, as illustrated here in the epidemiology and genetic risk map for Simicus and Markovnia from JACC 2022, both LPA concentrations and LPA risk allele frequencies vary markedly by country and by ancestry. This strong genetic control means that family history and ancestry are key considerations when deciding whom to test, and that a history of premature stroke or atherosclerotic cardiovascular disease should raise suspicion for LPA-mediated risk. Epidemiologic and genetic studies have consistently shown that high LPA increases stroke risk, especially in certain subgroups. As shown in this meta-analysis here, looking at 41 studies, higher LPA levels are consistently associated with increased ischemic stroke risk across cohorts, reinforcing its role as an independent contributor. LPA is particularly relevant, though, in patients from high-risk ancestral groups or those with unexplained or recurrent events, as seen here in this chart, showing percentage of patients with recurrent stroke on the y-axis and time from the incident stroke on the x-axis. The curves diverge quickly, with the patients with higher LP in blue developing more total and earlier recurrence. Taken together, this raises the question of when we should be measuring LPA in our stroke patients and how that information should influence secondary prevention strategies. Historically, there has not been consensus among society guidelines about the utility of universal screening for LPA, although some groups, such as the NLA, have been advocating for this shift for quite a while. In the US, the old AHA-ACC guidelines long favored a targeted, high-yield testing approach that focused on patients where LPA may clarify residual risk. Importantly, the newest 2026 AHA-ACC lipid guideline update has now called for universal screening once for all adults across their lifetime, which now brings us in line with the other major cardiovascular societies. Although stroke-specific guidance is still evolving, this approach aligns well with the patients we most struggle to risk stratify, particularly those with stroke before age 60, cryptogenic or recurrent stroke, or a family history of premature stroke or ASCVD, or those who may have coexisting aortic stenosis, which is also associated with high LPA levels. A few practical testing pearls that I wanted to go over. First, there are two reporting units for LPA, milligrams per deciliter and nanomoles per liter, and they're not directly interchangeable, so it's important to follow the lab's reference range. Nanomoles per liter, or concentration, is generally preferred as it better reflects the particle number, which best correlates with atherothrombotic risk. Remember, because the LPA particles vary in size due to those Kringle 4-2 repeats, two patients can have the same mass but very different numbers of circulating particles and therefore different risk. Second, LPA only needs to be measured once in a lifetime in most patients, since levels are genetically determined and stable by around 5 years of age. We only consider repeat testing if a patient is felt not to be at steady state. They have treatable thyroid disease, renal transplant, or some sort of acute illness that might skew the test. Importantly, fasting is not required, and repeat testing is unnecessary unless you have a different, more accurate assay that's now available to you. Finally, because inheritance is autosomal dominant, identifying an elevated LPA in a stroke patient should prompt consideration of first-degree family screening, particularly in families with early or recurrent cerebrovascular disease. Cascade screening is highest yield when LPA levels are markedly elevated, so above 100 milligrams per deciliter or 200 nanomoles per liter, but should be embarked with every patient with elevated LPA. When interpreting LPA, the key concept is that risk is continuous, not binary, even within each of these categories. There is no single threshold below which risk disappears. While population distributions and median levels vary across ethnic backgrounds, the incremental increase in ASCVD and stroke risk is similar across individuals once your LPA is elevated. In Black individuals and those of South Asian ancestry, baseline LPA levels tend to be higher, but that reflects genetic ancestry rather than differential biologic effect. So an elevated LPA should be taken seriously regardless of ethnicity, because the relative risk increase is consistent. It's also important to be clear about what LPA is not. It is not meaningfully modified by diet or exercise and is not reliably reduced by statins. In some cases, it may paradoxically increase slightly with statin use. That said, lifestyle modification and statin therapy remain cornerstones of secondary stroke prevention. The key point is that LPA represents residual, genetically mediated risk that sits outside of our traditional lipid management. So how do we manage this in practice? First, we optimize everything that we can control. This includes LDL-C and ApoB lowering, aggressive blood pressure control, diabetes management, and guideline-directed antithrombotic therapy. In terms of LPA-specific effects, PCSK9 inhibitors reduce LPA by about 20 to 25% and are currently the most practical option for lipid lowering. Apheresis can produce larger reductions but is reserved for very select cases. Niacin does lower LPA but lacks outcome data and tolerability in patients is poor. Importantly, emerging therapies, in particular antisense and siRNA agents, can reduce LPA by 70 to 90%, setting the stage for mechanism-specific stroke prevention trials in future. Until then, LPA should be viewed as a risk enhancer that justifies more intensive global vascular risk reduction. Managing LPA-mediated risk really requires a team-based approach. Neurology plays a central role by identifying these high-risk stroke patients, particularly those with early onset, cryptogenic, or recurrent events. Cardiology can then be looped in to help with lipid and global vascular risk optimization, while primary care supports longitudinal risk management over time. Importantly, this model also extends beyond the individual patient through cascade testing of first-degree relatives and forward into the future, as patients with markedly elevated LPA may be appropriate candidates for clinical trials targeting LPA directly. The goal here is informed, shared decision-making with patients around their genetically mediated risk. To make this more concrete, let's consider the example of a 48-year-old with a cryptogenic MCA stroke. Their LDL-C is already well controlled at 68 milligrams per deciliter on statin therapy, but an LPA is checked and comes back elevated at 180 nanomoles per liter. That result really reframes the case and identifies LPA as a risk enhancer and justifies escalation of therapy, such as adding a PCSK9 inhibitor to address that residual risk. At the same time, it triggers cascade screening in the first-degree relatives, shifting the focus from a single stroke event to prevention of future events across the family. So the key takeaways here are first, LPA is a true stroke biomarker, genetically determined, prothrombotic, and particularly relevant in early onset and cryptogenic stroke. Second, LPA testing improves risk identification with an easy, one-time, non-fasting measurement that can refine risk stratification in select stroke subgroups. Third, early partnership with preventive cardiology allows for more aggressive LDL and ApoB lowering when residual risk is identified. And finally, identifying elevated LPA opens the door to screening of high-risk relatives and increasingly increases access to mechanism-specific therapies that may fundamentally change secondary stroke prevention. For those who are interested in going deeper, the American Heart Association has some excellent practical LPA resources, including clinician guides, patient education tools, and materials to support family cascade screening. The QR code here links directly to those resources and is useful both for clinic workflow development and for guiding patient conversations. LPA can help explain the stroke that doesn't make sense and should change how we think about prevention. I thank you for your attention.